For those of you who are already here, welcome back to the final session of our MRCS revision series. Today we'll be focusing on a variety of questions, namely MCQs from examples from exams that have been previous, that your peers who have recently sat the exam have come up with in terms of thinking that they are high yield and worth going through. Obviously, this session isn't necessarily something that is designed to teach you, the theory. It's more to go through examples of questions, going through the rationale, how to approach them, hopefully give you guys some good tips. And then, with you guys studying hard for the exam in preparation for May, hopefully consolidate some of the revision that you have been doing. Today, before we do get started, we've got from our sponsors for this series, from the MDU, we have Chloe, who just wanted to give you a talk just before we do start. So without further ado, I will hand over to Chloe. Thank you for joining us today. And yeah, thank you.
No problem. Thank you, everybody, and thank you for that lovely introduction. Like I've already said, I'm not going to keep you too long listening to myself, because I know that's not the reason why you're here. So it's very much just sort of a quick hello from me. I'm going to leave you with some contact details, things like that. So that if you've got any questions, obviously, about your membership, or if you had any questions in general about indemnity, then obviously you've got a point of contact going forward, and just someone to contact, obviously, if you ever found yourself sort of in trouble and things. So there's a short little video at first I'm just going to play whilst obviously people are joining. Then I'm going to cover off some of the main facts, and then obviously I'll let you get sort of finished off and started, with your evening. Okay, so hopefully that was sort of a main introduction really as to sort of why we're here and what we do. And one of the main questions really that we get asked is, do you actually need to have membership from a defence organisation when you're employed by the NHS? So quite simply, yes. As much as if, for example, someone was to make a concern or a complaint about you, and if that did lead to being a settled claim, that's what the trust would be there for. So the trust would pay out to the patient in relation to that. However, they're not there to protect you and your professional interests and your career. So realistically, the reason you'd have that defence body behind you is so that obviously you've got help and support if you ever have to go to a hearing, help and support with responses, but also, fingers crossed, none of you will have concerns and complaints. So even if it's the case that you don't, one, obviously it's a GMC requirement, it's in obviously their good practice booklet to make sure that you do have obviously an adequate form of insurance or indemnity, of course. But also it's just important as well to know that you've got that advice line. As obviously you've just seen, we're run by doctors, it's for doctors, so it's the doctor that you'd speak to, it's 24/7, so it's important to make sure that you've got that support behind you. And this is really just to reiterate, like I say, this is taken from the guidance booklet, The Good Medical Practice, and it is obviously a statement within that they do say that it's important to make sure, you know, you must make sure that you do have either adequate insurance or indemnity when working, and especially if, for example, any of you are going to sort of go down a private practice route, things like that, then of course, obviously, you know, you definitely need indemnity if you're going to start private practice, so that obviously you do have what your patients wouldn't be disadvantaged if they did want to obviously complain. This is just a really nice graph that I'd just like to show you, and it just sort of really shows, you know, elaborates really and makes it quite clear as to where the MDU plugged the gaps left by NHS indemnity. So like I say, obviously for NHS work only is where the indemnity for clinical negligence claims comes through. We would obviously be your indemnity for any private income in relation to that. But then as you can see, as we go throughout, obviously it's helping support preparing cases, responses, you know, as the list goes on. And one of the main things as well to obviously note there is, obviously as a doctor, you are required to obviously help in an emergency situation. So if, for example, you're on holiday, a plane, wherever you may be, in relation to sort of Good Samaritan acts, then also your indemnity is provided from the MDU in relation to that. So obviously, you know, why is it that you choose the MDU? There's only really 3 main defence organisations that are out there. So it's important to obviously know the ins and outs of each one of them and choose the one that is right for you. The MDU is obviously the UK's leading medical defence organisation, and quite simply that talks for itself. I think it's important to talk to your colleagues, use the advice line, you know, use the services, because at the end of the day, if something was to go wrong, that's who's going to be defending you and your career. So it's really important to, you know, understand the benefits of membership, know how to access them, you know, having your online registration set up so that you can access you know, any documents that you may need, you know, nice and quickly, having the app, things like that, just knowing that, you know, if you're already a member, how to access them benefits. And if obviously you're not, you know, taking a look at the defence organisations and seeing, you know, who in your idea, you know, would be the better one to go with. Now, obviously, I believe that there's sort of a mixture of doctors on the call today, so this might be relevant for you and it might not be. But in relation to sort of foundation membership, if for your F1 year, it's £10 and then that's it as the full year. For your F2, it's £20 and that's it for the full year. And you get to choose one of the free gifts upon signing up, or if you're renewing and you're going through, and that continues as you go throughout. But once again, like I say, it's just important to know how to access their benefits and know where they are. And one of the main things with your foundation curriculum are the seminars that are designed for you guys. So you just need to speak with the postgrad coordinator in the trust that you're working, and they'll obviously arrange them and organise them. And it's just sort of another certificate to add to obviously your e-portfolios and add to obviously why you're going to be such great doctors and not have any complaints or concerns. Like I say, really as well, just to sort of round it up, you know, if you are already a member and you haven't obviously registered online, you can be a member but not have your membership. So you do just have to visit the website, set up your username and password, and then obviously you can access everything such as the journal, latest courses, online learning as well. There's lots of different ways, and we are starting up face-to-face learning as well. So if, for example, there was a particular course that was of interest and you wanted to come into the office, we are holding sort of days in relation to, depending on where you are in the country, in relation to that as well. So if that's of interest, once again, you know, accessing your membership and having a look and finding out them details, you know, is quite simply key. It's trying to get the message back out to you, because obviously we've not seen everybody over a couple of years. So it's just important to let you know that the information and support is there for you, and to not sort of forget to use it. If, for example, you're not a member and you do sort of want to apply and you want to have a look through membership, the one thing we obviously do ask is initially that you'd say yes to the emails. The only reason for that, and you can always change it later, is if you say no straight away, we literally cannot contact you. So there's 2 different questions. One's in relation to sort of updates to the journal, things such as that, so sort of medical information, support networks, and the other one's to do with your benefits of membership. So that's things like your renewals, things like your gifts, things like that. So we'd ask you initially to say yes, but you can always change it later on if you found that it wasn't really relevant to you. So finally, obviously, if you've got your phones on you or something, or you can screen grab, however's best for you, just take a photo. And like I say, I can be obviously your point of contact if you have any questions, if there's anything else that obviously you'd want me to follow up with. And if you did want to apply and have a look at the application forms, then that link there will obviously take you through to that. And the reason my name's there, it just means that it notifies me, so that if you've got any questions or help, then obviously I can do that. So thank you really very much for listening. I've tried to keep that as brief as possible for you all. I hope obviously you do obviously enjoy the rest of your training. Hopefully this course obviously is really good for you guys, and have a lovely rest of your evening. So thank you.
Thanks very much. Okay, so can you all see the screen? Okay, let's get started. So again, welcome back to the final session, guys, and we'll crack on. For those of you who joined a bit late, again, this is the final session of our MRCS revision series. It's going to be drilling questions, going through them, talking about the rationale, and any questions, again, put it in the Q&A and I can go through them as we go along or at the end, okay? So we come to our first question, and do answer in the polls, okay? A 6-year-old man is referred by his GP to the ENT clinic for a lump in the anterior triangle of his neck. The firm is 2 by 2 centimeter mass, seems to be fixed to the underlying tissue and moves with swallowing, but not with tongue protrusion. Which of the following is true of fine needle aspiration? So, okay, give it another 30 seconds or so. Almost half of you have voted. Okay, give it last 10 seconds. All right, let's stop it there. Okay, so for those of you who voted, majority of you went for C, that FNA is useful in a diagnosis of papillary carcinoma. And those of you who did go for that, that would be correct. So well done for those of you who did go for C. So we'll just talk about this. FNA is relevant in a variety of specialties, but particularly for thyroid lesions, it is very relevant because it's a good, useful way, which is minimally invasive, to get a sample. Now, I will just pop it onto this slide for a second. When you do take a biopsy, whether that's FNA, and usually for a thyroid mass that you're clinically suspecting, an FNA will be usually first line for a biopsy. And you grade that depending on the pathology and histology of the sample that you take in terms of those cells that you take from the biopsy. It will be graded from THY, Thigh 1 to 5, okay? 1 and 2 is essentially, you think it's benign, okay, not too much to worry about, let's keep an eye on it. 3 is essentially indeterminate, and it requires diagnostic hemithyroidectomy. Thigh 4 is, again, suspicious and requires diagnostic hemithyroidectomy. Psi5 is essentially almost confirming that there's going to be some form of malignancy there. Okay. I think for the exam purpose, just the two key things to know about FNA in regards to thyroid is that, first of all, it's really good for diagnosing papillary carcinoma. Okay. And again, remember, papillary carcinoma is one of probably the most common type of thyroid cancer, almost 70 to 75%. Okay. And commonly presenting, you know, between 40s, 50s in terms of their age. But yeah, remember that FNA is very, very, very good at diagnosing papillary carcinoma. Okay. And I know it's not on the slide here, but again, papillary carcinoma spreads by lymphatics. On the other hand, when we think about follicular carcinoma, and just going back to here, in terms of B and D, FNA is useful in the exclusion of follicular carcinoma, or that in B, FNA containing follicular cells is suggestive of malignancy. Actually, FNA in regards to follicular carcinoma, it can't be relied upon because remember that FNA is analysis of cells, it's cytology, okay? You're not taking a chunk like a core biopsy would from that thyroid. And although in papillary carcinoma, and we'll come to a bit later on about why it's good at distinguishing and diagnosing papillary carcinoma, an FNA for follicular carcinoma is difficult because you cannot say yes or no to whether it's follicular carcinoma or follicular adenoma. All right. And so hence, if you do get follicular type cells on your result, you would need a diagnostic hemithyroidectomy. And again, if that comes back as a follicular carcinoma, then you can do then further management such as completion, hemithyroidectomy if required, you can biopsy nodes, etc. But for exam purposes, just maybe from this question, 4 key points to know. FNA, very good for papillary carcinoma, poor for follicular carcinoma. And in general, management of thyroid lesions, you will do, in the first instance, a hemithyroidectomy before a completion total. And then remember that papillary spreads by lymph, follicular is spreading usually by blood, okay? Hematogenous. So let's move on to the next question. All righty. A 75-year-old woman falls down a flight of stairs. The paramedics conduct a primary survey. They immobilize her cervical spine and ascertain that she did not lose consciousness at any point. Upon arrival at the emergency department, examination reveals loss of motor function in all 4 limbs, with the upper limbs affected to a much greater degree than the lower limbs. Which spinal cord syndrome is this patient most likely to have? Okay, we'll give you about another minute for this one. 1/3 of you have voted. Another 20 seconds or so. Okay, let's stop it there. Okay, so we've got a spread of answers here. Quite a lot of you went for A, anterior cord syndrome. Some went for E, posterior cord syndrome. And there was a vote each for B, C, and D. Now, for this question, key points, essentially, in terms of things that will start to trigger thoughts in your head. You've got an elderly lady who's fallen down. Now, she's got affected immobility or weakness, essentially, to her all her limbs. But the key is that the fact that the upper limbs are affected much greater than the lower limbs. Okay. Now, there isn't anything about, you know, other things like temperature sensation or other somatic sensation that is affected in the stem. Okay, so you've just got motor effect that you're talking, and there is a disparity between how it affects the upper limbs to the lower limbs. And the answer to this question is C. It's central cord syndrome. Okay, and we can look at obviously why. And this is something that can come up quite commonly because it's an easy thing to ask about. And obviously you can try to essentially work it out in your minds if you can't remember what syndrome affects what or what generates what symptoms. And if you essentially know your ascending and descending tracts, you could try to you know, deduce what it is. Now, obviously, most people will recognize things like Brown-Séquard syndrome because it's something that's tested quite a lot in medical school as well. But in this question, we've obviously got just that motor information that I talked about. And so if we look at, let's just talk about central cord syndrome. First of all, you've got the inner aspect that's going to be affected. And in regards to central cord syndrome, a classic thing in terms of textbook, because clearly these are all quite rare presentations, it usually affects elderly patients who have, let's say, really bad osteoarthritis in their cervical spine, or they're very kyphotic in their cervical spine, and that they have a hyperextension type injury. Okay, and in this central cord syndrome, you get the upper limbs being affected a lot more than the lower extremities, because I know this image isn't very good, but if you look at, for example, the corticospinal tract descending down, that controls motor, like you have essentially in the motor cortex in your brain. The outer parts within the spine control your lower limbs compared to the upper limbs being a little bit more medially or towards the inner aspects. And so you get a greater effect of your upper limbs compared to your lower extremities. All right. And Brown-Séquard syndrome, most people, you know, there's always really good tables of these on some question banks that when you go through the questions, you can go through each one. I think the best thing is to try to, you know, get in, revise, study the ascending and descending tracks, and then you can essentially work it out going backwards. Okay. So know your patterns of injury within this, because it generally does tend to come up at least once. All right. So we've got a 60-year-old smoker with apical lung cancer and has signs and symptoms of Horner syndrome. Which of the following is not a feature of Horner syndrome? Just over half of you have voted, so I'll give it another maybe 15 seconds. Okay, let's end it there. So there was a split between C and D for this one, between endophthalmos and D, loss of lacrimation. Okay, the answer is D, loss of lacrimation. Okay, so clearly this man who's got an apical uncaster, this is probably a Pancoast tumor, which is essentially compressing on your cervical chain running in the neck. And you get some classic signs, obviously, with Horner syndrome. You get ptosis, okay, drooping of the eyelid. You get sorry, I'll go to this slide because it's better. You get meiosis, where you get essentially a constricted pupil, as you have unopposed parasympathetic drive in that pathway of the eyes. You also get anhidrosis, and you get a lack of sweating on the affected side. Now, the next, the lacrimal loss of lacrimation, essentially, because that is driven in tear production, it will primarily be driven by parasympathetic nervous system. And so as that will be preserved, you shouldn't get a loss of lacrimation, okay? And that's the reason why D isn't part of Horner syndrome. In regards to endophthalmos, which was the other answer, now it's almost like a pseudo endophthalmos. You don't get it, it's not necessarily a result of the loss of sympathetic drive that causes endophthalmos. You essentially start getting as a almost protective mechanism from, for example, the ptosis and essentially the absence of sympathetic nervous system. You start getting sinking of the eye in towards its bony cavity if it's left long enough without any treatment, and so that's why you get endophthalmos. Just something that comes up in Horner syndrome that's not necessarily widely known. I didn't know about it during the time of my revision, is a ciliospinal reflex. Okay, and this is essentially where you get pupillary dilatation caused by painful stimulus to either the head or neck, and obviously that's lost in Horner syndrome as well. Okay, because you don't have that parasympathetic drive to cause meiosis. Sorry, the mydriasis. Okay, so you don't get that pupillary dilatation. Okay, so a wordy next question. Essentially, an 83-year-old gentleman with a history of hypertension, hypercholesterolemia, insulin-dependent diabetes, and peripheral vascular disease suffers a transient ischemic attack involving causes temporary weakness of his left arm and left leg. Initial investigations include ECG and transthoracic echocardiogram that are normal. After complete recovery of his motor function, a carotid duplex ultrasound scan reveals a complete stenosis of the left internal carotid artery and a 71% stenosis of the right internal carotid artery. Which following treatment is most appropriate for this patient? Okay, so just over half of you have voted. I'll give you another maybe 20 seconds or so. Okay, so 2/3 of you guys have voted so far. All right, good. So I think we'll end it there. All right, so a lot of you went for C, bilateral carotid endarterectomy. Tricky one, because this is essentially based on guidelines, and it's difficult if you don't know those. And the answer here is B, it's the right carotid endarterectomy. And we'll just go through why. And it's essentially, based on the guidelines. Okay, so clearly this gentleman has, got lots and lots of risk factors for a TIA or stroke. And when they've had that carotid ultrasound scan, they've got a complete occlusion of his left carotid artery, and then 71% on his right. Okay, now if we look at the guidelines, it will essentially let us know why you would only do the procedure on the right-hand side. Okay, so essentially, if you look at the grading with mild, moderate to severe, the key number you want to be focusing on is 70%. Okay, now if there is an occlusion of more than 70%, that is an indication to perform the procedure, the carotid endarterectomy. Okay, as well as that, if they have a complete occluded artery or it's less than 70%, then they do not go for a carotid endarterectomy. Okay, so those are the two key facts to know about kind of carotid stenosis and whether they go for an intervention or not. I don't think for the exam you need to know any more than that. Okay, so yeah, you've got obviously other options, but in this instance, you would go for a carotid endarterectomy only on the right-hand side. Okay, now when you have a complete occlusion, essentially there's an endarterectomy would be very difficult actually making any difference, because it is, you're not going to be able to pass anything through that very easily. So another form of intervention would have to be considered for that. Okay, but remember, in the blood supply to the brain, you've got that circle of Willis, which is that anastomotic bed of vascular supply to the brain. So you're still going, if you've got one patent side, you're still going to have blood supply. Okay, so remember, for this type of question, 70% total occlusion, don't do anything. Less than 70%, don't do anything. Okay, so we on to the next question. We have a 76-year-old man who presents to A&E with sudden onset, severe tearing chest pain radiating through his back. His blood pressure is normal and equal in both arms. An ECG, chest X-ray, trot levels are essentially unremarkable. A CT aortogram reveals aortic dissection distal to the left subclavian artery, and this does not involve the abdominal aorta. How could you classify this pattern of injury? All right, so how could you classify this type of injury? Just Okay, all the votes are flooding in, so I'll give you another 10, 15 seconds. All right, let's end it there. All right, so another tricky type of question, just because clearly if you can't quite recall the classification, then this will be quite difficult to approach. Luckily, for aortic dissection, the classification, of which there are two to be aware of, they're not too hard to get a grasp of. And you'll find that obviously for the MRCS Part A, and I'm sure you've come to realize, there are a lot of classifications that you're expected to be aware of and know. Now, in terms of aortic dissection, you may get a question on it in regards to a trauma type setting. And that will be questions in relation to kind of resuscitation type things, your ATLS type things. It's unlikely that you would get anything on the specific operative or whatever management of that question, because that, and I don't think I came across many questions within question banks regarding that, or it didn't come up in my exam either. But classification of this did come up, and the answer to this is C. And 43% of you who did vote went for C. It's the DeBakey type 3A. And so let's just have a look at the grading system. There are two types, Stanford and DeBakey. Stanford is a bit more simple because it's only divided into type A and B. It's essentially type A, the ascending aorta, so the most proximal part of the aorta, is involved, and type B, the ascending aorta, isn't involved. So A is pretty simple and straightforward. Okay, sorry, I should have shown you this. So yeah, you got Stanford A and B, where regardless of how much of the aorta is involved, that is dissecting, where you've got a tear essentially in within the vessel wall. As long as the ascending part is involved, then you're going to be a type A, all right? And that essentially needs operative management. Type B, sometimes you could trial a little bit of conservative management, but it essentially doesn't involve the ascending aorta. The DeBakey classification is based upon 3 types, and 3 is divided into A and B. Okay, type 1, the ascending aorta is involved, okay, and it then descends into the descending aorta, okay. So you can see that the tear is involved in all aspects going down into the descending aorta. In type 2, however, it only affects the ascending aorta, okay. So you may think that obviously type 2 should probably come before type 1, but it's not in the DeBakey classification. How you split between 3A and B, so 3A or type 3, both types only involve dissection distal to the origin of the left subclavian artery, okay? So that's the key thing to distinguish type 3. It has to be distal to the subclavian artery. Where you have the distinguishing factors between A and B is that type 3A, okay, is essentially, it does not go below the diaphragm and extends to involve the abdominal aorta, whereas type 3B, it can extend down. And if it involves the abdominal aorta and it's distal to the left subclavian artery, then you've got yourselves a type 3B. All right. So, I found some classifications, I think, just from either knowing it from your clinical work day in, day out, or it's just one of those things that stuck quite well within medical school, can be straightforward or tricky. There were definitely some classifications that it took me ages to not necessarily even wrap my head around or understand. It just, you know, it just took time and needed repetition of questions and practice for it to sink in. So I wouldn't worry so much if, you know, classification-based questions are, you know, throwing you off or you're not doing so well. Just jot down the ones that you're having trouble with and then keep revisiting them frequently. All right, so we'll go on to the next question. We've got a 55-year-old lady who presents to her GP with a slow-growing, firm, painless mass in the lateral aspect of her cheek, is anterior inferior to her right ear. She's got no associated lymphadenopathy or facial muscle distortion related to it. What is the most likely diagnosis? Okay, so just over a third of you have voted, almost half actually now. Give you another 20 seconds or so. Okay, let's end it there. Alrighty. Majority of you went for C, pleomorphic adenoma, and that's the correct answer. So well done, guys. That was good. In terms of obviously this question, what you're trying to distinguish is whether you think some of the clinical signs or symptoms that they've listed here, whether they suggest malignancy or not, essentially. Okay. Now, in regards to the anatomical location that the question describes, it's in the area that you're thinking this is something that's affecting the parotid gland, okay, where it's just anterior inferior to the ear. And pleomorphic adenoma is probably, you know, by and large the most common parotid gland tumor, and they're, as the name suggests, is benign. Okay, so almost 80% of parotid gland masses will be pleomorphic adenoma. And key things in regards to these is just to know, obviously, when it's benign, you're very, very much less likely to have erosion of that benign mass into surrounding structures that are important. So, for example, clearly you're not going to have any lymphatic spread because it's not malignant. And also the facial nerve, those terminal branches that run through the parotid gland, you know, those aren't going to necessarily be affected because it's benign. And again, pleomorphic adenomas tend to be very, very slow growing. And as the question states there in the stem, it already says it's been slow growing. Okay. So those are the things that will primarily, you know, distinguish between A and C. And most of you obviously got this answer. In regards to calculi, it's going to generally be painful rather than painless. And they may, particularly as they're eating, for example, it may bring on the onset of the pain as well. Okay. Walton's tumor are benign tumors, okay, but they generally happen in very elderly people or in a lot more of the elderly population, okay. Obviously, adenoid cystic carcinoma just talked about, but it is the most common malignant tumor of the salivary gland, okay? And the question would generally, in the stem, say they've presented with facial pain when they eat, for example, with asymmetry because the facial nerve has been affected. All right. Great. So, and also with mumps, sorry, just going back, you're going to have other systemic symptoms, of course. Okay. So we've got the next question here. A 30-year-old woman is referred by her GP with a 3-month history of a painless lump in the anterior aspect of the neck. She does not describe any hoarseness of voice. Examination reveals a lump in the left anterior triangle, which moves up and down with swallowing. FNA cytology of the lump reveals nuclear grooves and intranuclear inclusions. What is the most likely diagnosis? Okay, give it another 5 to 10 seconds. I think pretty much most of you have voted. Okay, let's stop it there. Okay, so the majority of you, or most people who, 40% of you who voted went for C, papillary carcinoma, and that is the correct answer for this question. I think this is quite a tricky one in some ways, okay, and we can just go through it. Now, as I said earlier, papillary carcinomas are most commonly seen thyroid cancer. And we said earlier that FNA cytology is very, very good at detecting papillary carcinoma. And the 4 key descriptions of that, and you will probably be very familiar with orphan-anuclei or Samoma bodies, okay, because they're the ones that will generally always come up with question marks. Sometimes, if they don't give away those 2 trigger things to be like, okay, I see that in the question, it's going to be papillary, they may well just say things like nuclear grooves or intranuclear inclusions. Okay, and that is, I think, you know, when they do that, it's quite ambiguous and it can be unfair. But in this, sorry, the stem here, this shouldn't have, if the stem in this had the Samoma bodies, as I've highlighted here, you'd obviously just go for C, but sometimes they may exclude it. And in that occasion, look at the demographic of patient that they're showing, okay? And when it comes to that, you're thinking more, just because papillary carcinoma is the most common type. Now, you've got nuclear grooves and intranuclear inclusions from an FNA cytology, and if you put those together, you're to give you an actual diagnosis, it should point to papillary carcinoma. Okay, you know, this type of thing sometimes crops up in the exam where you think about it, you think, oh, it could be quite ambiguous, and unfortunately, they do include these sort of questions. Of course, like we saw in the previous question, if it was just on the FNA cytology, you wouldn't really be able to distinguish between A and B, okay? So that would be difficult, and that's probably why they aren't the correct answer here, all right? Medullary carcinoma is really rare. It's a carcinoma of parafollicular C cells, okay, and they secrete calcitonin, and you present with kind of endocrine type symptoms as well. And then anaplastic carcinoma, really rare but really aggressive type cancer that usually presents in really elderly women. So if you take both the demographic and the FNA cytology that they're asking from a diagnosis, just based on that, you're most likely going to choose papillary from the things that I've said. So I hope that is a bit clear. Of course, if you get psammoma bodies included, you're going to be, bang, papillary carcinoma, okay? But I just excluded that just to highlight some of the other key points you might want to focus on in the STEM where thyroid cancers are involved, okay? So next question. We've got a 45-year-old woman. They present to the breast clinic with 4 episodes of spontaneous blood-stained nipple discharge. Examination reveals no skin or nipple changes, masses, or lymphadenopathy. On expression, serosanguinous secretion is discharge from the opening of a duct. What's the most likely diagnosis? Okay, about half of you have voted. We'll give you a little bit more time. All right, we'll stop it there. Thank you. Okay, so a split between B and C. And Dr. Papilloma just edged it. A few more people going for C over B. In terms of breast, from what I can remember anyway, it was a lot of questions. When it was to do with breast, it was generally constellation of symptoms or signs, etc. What's the diagnosis? There wasn't many other questions within breast surgery that I can remember that came up on my exam anyway. There were a couple of things in regards to some of my other people who found that there was a random question on the breast screening program within the UK, but otherwise it was generally what's the diagnosis type question, okay? And so it's worth just going through the different types of breast pathologies, malignant or benign conditions, and knowing the distinguishing features for them. Now, again, we've got a blood-stained nipple discharge, essentially, from a woman who has no skin or nipple changes and no masses or lymphadenopathy. So that the fact that there are no skin nipple changes, things like peur d'orange or things like that, you're thinking a little bit less of, is this malignant? Although you can't rule it out, you're thinking, okay, maybe it isn't. And the correct answer for this was C, Dr. Papilloma, okay? And just over half of you who voted did go for that. All right, so why Dr. Papilloma over Dr. Ctasia for this question? And it's tricky because obviously things aren't ever absolute. But in terms of discharge, when it's green, in the question, generally, greeny discharge, it's generally going to be duct ectasia, okay? So duct ectasia, essentially you get dilatation of the larger mammary ducts within the breast, and they fill up with essentially fluid, and it's generally usually a bit green, and that's what's expressed. Generally it occurs, duct ectasia usually occurs a little bit more in, for example, perimenopausal, all right? And patients may have typically slightly tender or lumpy breasts that come in with green stained nipple discharge. Duct papilloma, on the other hand, they can cause a bloody tinge in the discharge that they produce. And obviously in this question, it says they've got bloodstained nipple discharge, serosanguinous secretion. And the duct papilloma, it's not pre-malignant, but it can cause bloodstained discharge. Okay, so try to distinguish duct ectasia to blood, green, and duct papilloma to blood. And otherwise, clearly galactorrhea and prolactinoma generally won't produce bloody discharge. It'll just be creamy, thick, white, cloudy discharge. And the breast abscess also wouldn't really produce a bloody discharge. Okay. So a 65-year-old painter complains of weakness in his right leg after falling 3 meters from a ladder. His GP performs a full neurological examination and discovers a diminished Achilles tendon reflex on the right. Which nerve is involved in the Achilles tendon reflex, and what are its nerve roots? Okay, so I'll give you a little bit more time. Half of you have voted now, so I'll give you about another 20 seconds or so. Okay, let's end it there. Okay, thank you. So spread of answers between B and E, but 46% of you went for D, and that's the correct answer. So myotomes, dermatomes will come up either as an anatomy type question, or it could be kind of incorporated into something like this. And sometimes you may be thrown off a little bit because you might know the myotome, but you can't quite remember what nerve it is that actually supplies that. And so, you know, that's the tricky part really in this, isn't it? So the Achilles tendon reflex, S1, S2, but it is, remember, obviously, the reflex is that action of a plantar flexion at the ankle, and to plantar flex, you will essentially be using your posterior compartment, and the nerve that runs there is the tibial nerve. All right, so that's a way to try to think through what nerve it is, because I'm sure you've got it drilled in your heads about the myotomes. Okay, so that's just a way. Just think of what the reflex is, what movement is, what muscles then, or what compartment is responsible for those muscles, and what is the nerve that runs through that compartment. Okay. So we have the next question. A 32-year-old woman presents to the emergency department with acute severe occipital headache. Subsequent lumbar puncture and CT imaging demonstrate a subarachnoid hemorrhage. Despite an apparently early recovery, the patient's level of consciousness begins to deteriorate 4 days after the onset of her headache. Which of the following options describes the most likely cause of this sudden deterioration? Okay, give you another maybe 20 to 30 seconds. Okay, let's end it there. Great. So we've got a mix between, largely between A and C for this question. And the answer to this one will be A, it's Hydrocephalus, for those of you who went for that. Well done. So this is, it's quite tough in regards to, just because clearly in terms of neurosurgery, you don't get a huge amount of exposure to it clinically anyway, unless you've worked in, you had a job in it or rotated through, for example. But this patient's had a subarachnoid hemorrhage. They've come in, diagnosed as subarachnoid hemorrhage, and has had an, it says that they've had an early recovery, which lasted, it seemed, for 4 days until she's, deteriorated again suddenly. With bleeds and subarachnoid hemorrhage, obviously, mortality is pretty high. And the big risk really is rebleeding. And if that's the case, they'll need, for example, an emergency clipping of that vessel that's bleeding. But there are obviously other complications that you can get as well. And when you have some of these risk factors, now, in terms of an abscess developing, there's no mention of evidence of infection within the question. And again, it would be pretty, it's just too soon of a timeline in terms of 4 days for that to develop. And, quite rightly, none of you went for that option. Meningitis, again, completely different type of presentation, really. They've already given you a diagnosis. So to have a double whammy of having meningitis on top of that would be pretty unlucky. And, that's not the cause of what's happening here. Again, sagittal sinus thrombosis, potentially, but I think, again, with that, the timeline of things that are happening are a bit too soon. And when you're having, bleeding, it's unlikely to then have thrombosis concurrently at the same time. So, it's unlikely to be E, sagittal sinus thrombosis. That leaves you with A and C. You've got medullary coning, which is clearly going to be most likely fatal, or hydrocephalus, where you've got essentially an obstruction within the flow of CSF through the ventricles, etc., causing that increased pressure and leading to hydrocephalus. Now, I think the main reason really why hydrocephalus is that A, it fits the timeline. It can happen in the first few days, okay? And generally, you can see a progression of gradual, possible improvement early on, but then you get that sort of deterioration as it reaches a point in which, the hydrocephalus then starts increasing the intracranial pressure as well. Okay, and that's in a case where the bleed isn't, it's not absolutely catastrophic, where you could try to still salvage this lady. She's very young as well. Okay, so in terms of just these types of stems, I think the key thing to try to think about in terms of hydrocephalus in the context of subarachnoid hemorrhage is that they may show a small improvement over a couple of days, 3 days, but then again, gradually deteriorate again. If it was coning because of increased intracranial pressure from a bleed, you get a pretty rapid deterioration straight away, and you wouldn't really see that upslope in maybe the patient's condition before that deterioration. Okay. And clearly it would generally be the blood that causes that obstructive factor in causing the hydrocephalus. Okay, so moving on to the next question. A 60-year-old man presents with dysphagia and heartburn. He undergoes gastroscopy, which shows evidence of Barrett's esophagus. Which of the following options best describes the pathological process in the development of Barrett's? Okay, we're pretty much there, so we'll stop it there. Good. All right, so we're split between the two metaplasia options, because metaplasia is the pathological process that that happens in Barrett's. So remember that obviously the esophagus, the normal epithelium would be squamous. Okay, non-keratinized squamous epithelium in the esophagus, and you get probably most likely from back reflux or washing of gastric acid, etc. And you slowly get metaplasia, because metaplasia is the differentiation of one mature cell type to another, and you get metaplasia. Now, is it squamous or columnar? When it states let's say, for example, columnar metaplasia, okay, which is the answer for this question, it's referring to the end cell type that the metaplasia has changed to. Okay, so squamous metaplasia would mean the differentiation of one cell type to another is ending in squamous. Okay, so in Barrett's esophagus, it's columnar metaplasia, because you get a differentiation from squamous into columnar epithelium. Okay, obviously examples of squamous metaplasia, on the other hand, would be, for example, in cervical cancer, cervical cancer. Dysplasia is not the process that happens in Barrett's esophagus. Anything that's dysplastic is pre-malignant, and that generally happens from abnormal development in cells. Okay. Hypoplasia and hypertrophy clearly isn't what's going here. Just remember, obviously this is a little bit more physiology, but hypoplasia is the increase in cell number. Okay. Hypertrophy is the increase in the cell size, so the size of each individual cell. Okay, so it's just obviously one takeaway, apart from knowing that Barrett's esophagus is squamous to columnar, is that when you're describing metaplasia, whatever the end cell that is being differentiated into is the one that's going to be in the term. Okay, so a 60-year-old male presents to his GP, 3-week history of sweating, headaches, constipation, and itchy lesions over his back. On examination, the BP is 166/94, and his heart rate is 104 beats per minute. 24-hour urinary catecholamines, metanephrines, and vanillamandelic acid are found to be elevated. A CT scan and a 131 meta-iodobenzyl guanidine scan confirm the presence of pheochromocytoma. The patient subsequently is found to also have medullary carcinoma of the thyroid. Which of the following is the most likely diagnosis? The wordy stem. Give you a bit of time for this one. Oh. Okay, a few more seconds. Pretty much there. Yeah, let's land it there. Yeah, so, more than essentially 2/3 of you have went for C, MEN2A, and that's the correct answer. Okay, so well done for those who got that. So yeah, obviously things like MEN, it's just something that's comes up all the time in the question bank. So, just drill them, and hopefully within time you'll see the patterns and recognition. Obviously, lots of people have different ways of remembering them. But so, for example, MEN1, the 3 Ps, etc. 2 Ps for MEN2A, 1 P for MEN2B. But knowing what those Ps are is clearly also important. In this patient, they had a diagnosis of pheochromocytoma, which doesn't present really in MEN1. It's one of the type 2 multiple endocrine neoplasias. And they've also had a diagnosis of medullary carcinoma, okay? And obviously that is also part of MEN 2A and 2B. Now, so essentially, going back to this, we had to distinguish between types 2A and 2B, really, isn't it? And so what you are looking at here, because some of the clinical signs, it suggests all the things, and they've given us the diagnosis anyway, right? The main thing is that MEN2B, and it's not, it shows here, it's essentially, it can be MEN2A, but generally they have Marfanite features. And they would state that in most stems, really. Otherwise, it'd be very, very unfair for them. So MEN2B is essentially characterized by MEN2A, but they're generally Marfanoid features, okay? And they can also have neuromas, all right? But yeah, that's the main thing that I remember, or I try to remember, that as soon as you see kind of Marfanoid type features, think That's the distinguishing factor between 2A and 2B. All right. So go on to the next question. Okay. So we've got a 50-year-old woman presents to her GP 7 weeks after her renal transplant procedure. They've got polyuria, polydipsia, and abdominal pain. Her blood tests show the following: corrected calcium of 2.9, phosphate of 0.69. What is the most likely diagnosis? Okay, I think we're pretty much there, so we'll end it there. Okay, good. Yeah, so a split between the hyperparathyroid options, and you've got primary, secondary, and tertiary there. The answer for this question is E. It's tertiary hyperparathyroidism. Okay, we can just go through why. All right, but a simple, crude way of just thinking about the three is that primary parathyroidism, generally the most common cause is some form, a parathyroid adenoma. You get a adenoma, a nodule, something within the parathyroid hormone, parathyroid gland, sorry, that they produce PTH, and that essentially causes hypercalcemia as a result. Secondary hyperparathyroidism is essentially something that you get where you get excessive PTH hormone secretion from, for example, renal failure or chronic kidney disease, for example. Okay, and that's obviously because when you have kidney disease, if you think back to calcium homeostasis and the role that the kidneys have, which is a pretty big one, you will have less activation of vitamin D that happens in the kidneys. You get less reabsorption of calcium. You get less secretion of phosphate, for example. And so you will, for example, just taking reduced activation of vitamin D, you're going to have less calcium absorption in the gut. So the parathyroid glands produce PTH, and that goes on and on. When it turns tertiary is if that process goes long enough, secondary then can turn into tertiary when the parathyroid glands that are generating PTH in response to all of this, they become autologous and they just keep generating, even if you take that stimulus away. And the big clue in stems, even if you don't look at the numbers, clearly it's important to do so. But if a stem says it's a renal transplant patient, it suggests that they've had end-stage kidney disease for a long time, in which they've had time to develop tertiary hyperparathyroidism, but long enough to then those parathyroid glands to start just auto-generating PTH, okay? And this is obviously a table. There are loads of tables that will show you kind of the patterns in which parathyroid, calcium, phosphate, all of these levels differ in how to interpret. You can go through this, you can learn it, and if you can, that's really good. But just remember, it can help by knowing the causes for each two, because that will give you a good feel from the stem to think, actually, surely it can't be tertiary because there's no mention of kidney disease or renal transplant, etc., etc. Yeah. So those are the things just to keep in mind of. And obviously, and I'm sure you're going through in your revision, going through the different patterns, you know, you've got these sort of things. A similar thing is your bone mineral levels in your, you know, in the differences between osteoporosis and osteomalacia, all of these things. So when you go through question banks and practice, those are the things that will, that you'll drill. Okay. So a couple more questions. Sorry, we started a bit later today, but we'll carry on. A 55-year-old lady presents to the breast clinic with a 1-week history of a left breast lump. She was involved in a car accident 1 month previously. Car was hit in the rear by another car. She only suffered minor symptoms of whiplash after the accident. Her past medical history includes diabetes and hypertension. Sister was recently diagnosed with breast cancer. Examination reveals a small, mildly tender nodule in the upper outer quadrant of the left breast. What is the most likely diagnosis here? Okay, just over half of you have voted, so we'll give it another few seconds. Okay, give it another 10 seconds. Okay, we'll stop it there. Okay, so the majority of you went for C, fat necrosis, and that's the correct answer. Again, just one of those things that you're thinking about when it comes to breast questions, breast lump questions. One thing to note in breast conditions is if you have a tender lump, that's actually quite a reassuring sign, okay, because it means it's less likely to be malignant. Okay, malignant lesions generally, by and large, tend to be painless, okay? So obviously they've, you know, within the question, they've got things like, for example, the family history of breast cancer, etc. But that's more of a red herring. You want to think, what is the history here? Okay, they've had a recent potential trauma because they've been in a bit of a car accident, although there was no severe injury. She could have knocked something. And generally, fat necrosis, okay, patients who present with that will have some form of recent trauma to the breast within the question, okay? Mechanism of injury, actually, you know, it can be very minimal or it could be quite, you know, severe, but generally you'll have some form of trauma. And fat necrosis, also you get a tender lump with it as well. So those things fit with this question, okay? Again, the red herring in terms of the family history of cancer, ductal carcinoma wouldn't present with pain, okay? So the reason, due to the fact that there's some form of trauma here, means that fat necrosis is the overwhelming likely answer, okay? So a couple more questions to go. We'll go on to the next one. Another thyroid question. So 30-year-old woman presents with a 6-week history of weight loss and anxiety, no regular medication. She smokes 10 cigarettes daily. Examination reveals a resting heart rate of 108, a fine resting tremor of the hands, lid lag, periorbital edema, a diffusely enlarged diffuse goiter is noted with a non-tender 2 centimeter nodule on the right thyroid lobe. Initial blood tests reveal T4 of 31.5, which is high, TSH level of 0.10, and the presence of thyroid peroxidase antibodies. Radioisotope scanning of the thyroid reveals a diffuse uptake with no uptake in the right nodule. What is the most likely diagnosis in this patient? Just over half of you have voted, so I'll give you guys another 15 seconds or so. Okay, let's end it there. So quite a split, guys, for this question. Quite a few of you went for C, Hashimoto's thyroiditis. I think this is quite a difficult question. It would be more towards the difficult end of the spectrum, probably. But the answer here is D, again, papillary carcinoma of the thyroid, which has been an answer for quite a few of the questions of this evening. Let's just quickly talk about why that is for this question, okay? And I think there are maybe 2-3 key points to take away for this one in tackling it. Essentially, when you just look at this in terms of the clinical signs, okay, the reason why it's not Hashimoto's, remember Hashimoto's thyroiditis is a form of hypothyroid, autoimmune condition in which you get low thyroid production, okay? Now, the fact that within the biochemistry results of this question and the T4 level is high and the TSH level is low, it cannot be Hashimoto's thyroiditis, okay? We can rule that out. All right. In terms of, and now I want to talk about why it is the papillary carcinoma of the thyroid. Now, if you read this stem, probably until the last couple of lines, you're thinking, okay, this patient has all the clinical signs that fit with hyperthyroidism or thyrotoxicosis, for example. They've got fast heart rate, they've got resting tremor, they've got lid lag, periorbital edema, and you know, they've got a diffuse goiter, and the blood tests would fit a hyperthyroidism, and they've got the presence of a thyroid peroxidase antibody. That all fits with Graves' disease. All right, so that's the autoimmune condition that would fit high producing thyroid T4 hormones. But that isn't an option in our question. So why is it then papillary carcinoma? So if you leave Graves' disease long enough, it can then predisposed to malignancy. And in this question, there are 2 bits that should tell you is what's this going on. There's a non-tender 2 centimeter nodule, so there's a lump present. And then on the radioisotope scanning, although there's diffuse uptake, there is no uptake in the right nodule, that nodule that they found in the right thyroid lobe. So in malignancy, in thyroid, radioisotope scanning, you don't get uptake of that if it's malignant. So if you get diffuse uptake, for example, or uptake, that's again, like when I said with breast lumps, if it's painful, it's reassuring. If you get uptake of radioisotope, again, that's more of a reassuring thing, that it's less likely to be malignant. But this one, there isn't there. All right. So that's why it's D. And so there are a couple of layers to that question, which makes it a bit tricky and difficult. Okay. But that cold sign where there's no uptake in the right nodule is highly suggestive of some form of cancer in the thyroid. And that's why you want to be thinking, okay, which one is it? Okay. And remember the eye signs in this, just as an aside, Graves' disease is really, really, the eye signs fit with Graves' disease. Remember in your clinical examination of the thyroid, when you do, when you've been doing OSCEs, for example, you check for those eye signs, and that's linked to Graves' disease. Okay. And the most common cancer that comes from Graves is usually papillary, and that's why it's D over B. Okay, so the next question, and sorry, there's no poll for this, so you can, just do it on your own, guys. A 60-year-old man is found by his GP to have a non-healing ulcer on his left lower leg. He recalls having suffered a burn to this area over 20 years ago. Despite debridement, skin grafting, the slowly progressive chronic ulcer has not resolved. And on examination, bilateral pedal pulses are palpable. There's no evidence of venous insufficiency. The ulcer is painless with an irregular everted edge. The surrounding skin appears chronically inflamed and exhibits non-pitting edema. What's the most likely diagnosis? Okay, so sorry about the lack of poll for this one, but just obviously jot down the answer in your own minds, and then we can go through it. I'll give you about 10 to 15 seconds. Okay. So the answer to this question, if you've had a think and had your answer, okay, is C, is Marjolin's ulcer. And this will be coming up in your question banks fairly frequently, I'd imagine. Marjolin's ulcer, they're slow growing, okay, and they are essentially squamous cell carcinomas that arise from previously formed ulcer that are traumatic, or you have, for example, chronic inflammation of the skin. Okay, so they are malignancies that form slowly. Their type is squamous cell, okay, and generally you'll have a long, drawn-out history of the presence of, for example, an ulcer that is there. And that's why for this question, it's Marjolin's ulcer. That's the answer. Okay. Again, the fact that it's painless, it doesn't necessarily fit with things like it not being arterial ulcer, for example. Basal cell carcinoma just doesn't present like this. And I'm sure you've, when you've studied, the pearly edge, for example, all of the clinical signs that point to a basal cell carcinoma. Okay. And so, yeah, that's Marjolin's ulcer. Okay. Okay. So that is the last question of this session. Thank you very much for tuning in. I know that it was advertised as kind of neurosurgery / ENT, but given that it was last session, I just wanted to make it a little bit more varied and mixed in regards to those. Obviously, if you guys have any questions generically about the exam itself, anything in regards to that, doesn't have to be specific to this session, please ask it in the Q&A section, and I'm happy to try to answer it. There is a link in the chat that has a feedback, as well as you can scan this QR code to provide us some feedback, which would be really good. And thank you for those who have been tuning in throughout this webinar series, who have filled up the feedback as well. On top of that, I hope the series has been useful. Obviously, within the time allotted, it's very, very difficult to cover the whole curriculum, that's why we wanted to try to just go through as many questions as we could. But very, very good luck to you guys in the upcoming exam. It is quite a tough, it's a tough gig. Part A, definitely, I think, more challenging than Part B. But yeah, I'm sure you're all working hard. Very best of luck. And yeah, if you can provide that feedback, that'd be great. If you don't have any questions, and I can't see any in the Q&A, then obviously enjoy your evenings as well. Just little things, obviously, about the exam, the evening before. I'm sure people really do say, oh, avoid cramming, staying up late, etc. But yeah, it really does help in terms of trying to get a good night's rest before the exam, because the actual day of the exam will be incredibly intense. You've got a 3-hour paper in the morning and a 2-hour paper in the afternoon. It's a really long day. And so make sure you're well rested the day before. Little things that I did to try to help, other than going through the question banks, etc., is to, some of the things that you find yourself getting wrong when you do the question banks quite frequently is just essentially make a note of it, whether that's classifications of things, certain conditions that you just look up, or even if it's the MEN stuff, for example, just have a few core things that you can go through concisely, a day, 2-3 days before the exam, just to refresh your memory of those things, and then go through it. And yeah, I think there aren't any questions apart from one which says, okay, and we've provided a link to YouTube. I want to thank Musa, who's been moderating these sessions, providing us with all the links and ensuring that the sessions run really smoothly. So thank you very much, Musa. He's been behind generating all the polls as well. So thank you very much, as well as the rest of the team at National Surgical Teaching Society. Okay, so I think that's a good point to end it there. Thank you very much, and enjoy your evenings.